see for the scrapings, we have the investigations. We will take the scrape and then we will investigate it further on. Okay, after that we will be having the question number 101. The question number 101, a 50 years. 101 we will be having, say 50-year-old locksmith has long term. So what we have, a long term record of work under the effect of mercury vapors. So mercury is they have the intoxication effects. So if the mercury will be given in the questions, it will cause the mercury intoxications, and its concentration exceeded MPC by 5 to 10 times. Clinical reliability of the vasomotor of the skin's pulse and the arterial pressures, total hyperhidrosis, asymmetric innervation of the facial and the lingual muscles. So these all are the features of the mercury intoxications. In this condition we see the parodontosis, means there is a problem in the teeth also. So these will be seen. The next question will be having like 4 hours after having a meal. So you have seen the 4 hours after having meal, a patient with sign of malnutrition and the steatorrhea experience the stomach pain, especially above the navel. So you see there is a patient having the chronic pancreatitis, and everything we have discussed. So if you see there is a especially above the navel and to the left of it. Diarrhea take turns with the constipation lasting out 3 to 5 days. Palpation reveals moderate painfulness in the choledochopancreatic regions. The amylase rate in the blood is stable. The amylase is not increasing. Some amylase we discussed that it is seen in pancreatic insufficiency. X-ray reveals some calcification. So here we have the keywords, that is if you see any calcification, any pancreatic enlargement located above the navels. So this is the case of the chronic pancreatitis. So remember, if it is the case of the chronic pancreatitis, in chronic pancreatitis, firstly we do the CT scans, and we will what will be the diagnostic features or the clinical features we will see. What will the diagnostic features in the CT will be seen? If you see the pancreatic calcification, will be there. Pancreatic calcifications, or you also see the pancreatic ductal dilatations. Pancreatic ductal dilatations. Okay, bile duct also can be involved. So all these are the diagnostic features that we seen in the case of the CT. Other things we already studied about the chronic pancreatitis. After that, the next questions. In the next question, we have seen that a patient physician and suffer from the general weakness. The fatigue will be there. Mild pain in the sometimes frequent painful urinations. Splenomegaly has been revealed. If you see the splenomegaly, that is the characteristics feature or the clinical features of the chronic myeloid leukemia. Blood test neutrophilic leukocyte with the progress to the myelocytes. So we have seen the neutrophilic leukocytosis with the progress to the myelocytes. So basophils 2%, eosinophil 5%. There is a urate crystals in the urine, erythrocytes. So all these are characteristics of the. If you see the neutrophilic leukocytes progress to the myelocytes. So myelocytes is increasing. So myelocyte is increasing. That is the myeloid leukemia. That is the myeloid leukemia will be there. That is the myeloid leukemia will be there. So this CML we have discussed before, that it is the cancer of the white blood cells, in which we see there is a rapid growth of the myeloid cell in the bone marrow. There is a rapid growth of myeloid cells, and there will be you will see undifferentiated myeloid cell. If more means that is a undifferentiated myeloid cell will be there. Okay, other than that we see there is a splenomegaly will be also seen. Splenomegaly will be also seen. So that everything we have discussed already, like if the blood stem cells, so we have the two stem cells. One we have the myeloids, and another one we will be having that is the lymphoid. Then the myeloid stem cells, they release the myeloblast, red blood cells or the platelets. Lymphoid blast, they release the lymphoblast, B lymphocyte, T lymphocyte, natural killer cells. So everything we have discussed in our pediatrics class in leukemia. Then remember, if you have seen the diffuse toxic goiter with the ciliary arrhythmia, सब सही चल रहा है ना? ठीक है, बढ़िया है. So there is a 56-year-old patient with the diffuse toxic goiter. So we have seen the diffuse toxic goiter, ciliary arrhythmia with the pulse rate of 110, arterial hypertension is more. What preparation should be administered along with the mercazolil? So see, This is the case like when the patients will be having taken the mercazolil. So this patient will be having the hypertension. This patient will be having the hypertension. So with hypertension, what we will give? We will give the propranolol. Propranolol is the non-selective beta blockers. It is a non-selective beta blockers. And I told you it is contraindicated in which condition? It is contraindicated in asthma patients. Okay, so and here we have to, why we are giving the propanol along with the mercazole, because this is helpful in the production, or it helpful to prevent the blood pressures in this patient. Okay, the next question is what, that if 54-year-old patients complain weakness, weight loss despite the unchanged appetite, frequent urination, skin itch for 6 months, sometime ago the patient underwent the treatment for furunculosis. What is the treatment for the furunculosis? She has not been examined recently. Objectively, malnutrition, dry skin, sign of scratching. Small lymph nodes can be palpated in the axillary region. Changes in the internal organs are absent. What testing must be administered in the first place? So I told you the furunculosis, carbuncles, all these are associated with which conditions? They are associated with the diabetes mellitus. So they have the risk will be increased. Diabetic mellitus risk will be increased if the patient of the furunculosis, and due to which we will see that like changes in the internal organs are absent, and we have seen the malnutrition. So all these are associated, frequent urinations, okay, weight loss. So all these are associated with the diabetic mellitus. For confirmations, we will do the test. And how you will do the test? We do the test, diabetic mellitus test, on the blood sugar test on the empty stomach. Why the empty stomach? Because if the patient will be having taking the food, we will be having the glucose. Food will be having the glucose, and to when the glucose will be in the body, we having the hormones, insulin and the glucagon hormones. Glucagon, you know, that increase the glucose. Insulin, what they do? They decrease the glucose. So the bad result will becomes. So the result will not be that what we want. Okay, false result will be there. So that's why we will do on the empty stomachs. Any test like CBC also we do on the empty stomach, because we are taking the food, and their food having some bacteria particles can be there, and these bacteria particles can increase the neutrophils in our body, and we will get the false results. That's why we having that, we also done this test in the empty stomach. Okay. This question I gave you yesterday, so correct this. This is not the perforative ulcer, this is the acute cholecystitis. If you see, there is a bitterness in the mouth. There is a bitter. I shared the 3 questions in the hygiene group. So what we have seen, bitterness in the mouth. So what is the bile? That is the bile. Multiple vomitings without relief. Patients related the onset of pain to the taking of fat and the fried foods, and also they are given the right hypochondrium tense. So this is the case of acute cholecystitis. This is not the perforative ulcers. In perforative ulcer, you will see the bleeding will be there, and the patient will be having some hemoptysis, hematemesis. So all these things will be there, but here nothing has been mentioned. They have mentioned simplicity, that bitterness in the mouth, there is a right pain in the right supraclavicular area, that is the sign of the acute cholecystitis. And you will see there is a fat, a patient was having given the history of fat and the fried foods, means something is history about the, that we see in such content we will see, that we will see in case of the in case of acute cholecystitis. हाँ तो अभी करवा देना. That's why I changed the answer. That is the, in the test center the answer is the perforated ulcers. Test center में perforated ulcer है. और it was crocology or in the test center. Test center के अंदर है. In crocology also they choose the answer. Why it will be the perforative ulcers? पर क्या ना भाई, और सेंडिंग मी हियर, बाद में बात करते हैं, मेरे को लगा ये वाला क्वेश्चन सेंड कर रहे हो।
ओके भैया।
ठीक है, this question if it's given in the test center website, I don't know what to choose. Okay, I will check it this question again, but it should be the acute cholecystitis because there is nothing has been mentioned regarding related to the perforative ulcer. But if it is in the test center website, then we will consider it, and I will tell you like how you can do. If for online exams you can go for perforative ulcers if the online exam is there, but offline exams uh, don't go for the perforative ulcers. First we need to confirm, maybe something is missing in these questions. So the perforative ulcer, if it is given in the test center website, then go for the only online exams, choose the perforative ulcers. ठीक है, बाकी इसको देखते हैं क्या होता है क्या नहीं. After that, several hours before, a 28-year-old patient suddenly developed acute headache and repeated vomiting, then lost consciousness. Focal neurological symptoms were found. Pronounced meningeal symptoms were revealed. AP, according to the clinical and liquorological finding, the patient was diagnosed with the subarachnoid hemorrhage. After administration of the dehydrant matlab like some diuretics type of the things, the patient condition somewhat improved. What is the main component of further emergency care? So if you see the patient having the subarachnoid hemorrhage, the subarachnoid hemorrhage, what is the, it is caused by the rupture of circle of Willis. Okay, rupture of the cow, that is the circle of Willis will be there. So in the circle of the Willis we will be having that the circle of Willis, or if the rupture of the circle of the Willis, so that means we will be having the subarachnoid hemorrhage, and in these conditions we will see these patients will be having given the loads of bleeding will be there, and due to control that bleeding, so we will give the treatment, that is the coagulant. We will give the coagulant. And if they ask you the drugs, then drugs you can give, that is the vitamin K. Drugs you can give, that is the vitamin K, and there is the phylloquinones or manadiones. Okay, like there is the two type, fat soluble vitamins or the like vitamin K, it can be the natural or the synthetic. So if it is the naturals, then the phytodiones or the phylloquinones, but if it is the synthetics, you can go for the minadiones. They can give you in the question, this phylloquinone or manadione. So all these drugs we can be given in case of the subarachnoid hemorrhage as in the form of the coagulants. Then remember the acute viral encephalitis, the treatment we will give for emergency care, that is the Jovirax. So remember these drugs, this is given in case of the acute viral hepatitis, acute viral encephalitis. In case of the acute viral encephalitis, we will use these drugs. The same question. After that, we have seen that delivered to admission ward of infectious disease department. Disease has started acutely in the background normal temperature with the appearance of the frequent liquid profuse stool without pathological impurity. So what you have seen, the appearance of the frequent liquid profuse stool without pathological impurity. Diarrhea was not accompanied by the abdominal pain. 12 hours later, they appeared recurrent profuse vomiting. The patient rapidly developed the dehydration. What is the most likely diagnosis? So we have seen that patient, if there is frequent liquid profuse stool, means that is around 20 liter stool will be there. So that is the isotonic stool, and that will be around 20 rice water stool. Rice water stool will be there, and the milky, or in the question they can give you the milky stools. Rice water stools or the milky stool will be there, and it will be around 15 to 20 liter fluid will be lost. So that is seen in the cholera. Okay. The patient will be having the rapid pulse, tiredness, dry skins, vomiting. All these are the clinical features we seen in the case of the cholera. And it's caused by which condition, which bacteria? Vibrio cholerae. It is caused by the Vibrio cholerae. After that, a patient complained of mouth opening following foot trauma 10 days ago. So this patient will be having the foot trauma 10 days ago. Now what we have seen, there is a complicated mouth opening. We have seen the complicated mouth opening following the foot trauma. So we know that if any foot trauma or by trauma by any iron particles, so in that conditions we will be having, see, we have seen that these patients can lead to the tetanus infections. ठीक है, नॉर्मली इन आवर होम्स आल्सो इफ यू से कि टेटनस हो जाएगा, जल्दी से जाके इंजेक्शन लगवा ले, ठीक है, तो दैट इज व्हाट टेटनस. नाउ सी एट विद द डिफिकल्टी, देयर वाज अ मसल्स टेंशन ऑफ the back of the head and abdomen. On the third day there was a tension of all muscle group, generalized convulsion every 10 to 15 minutes. What is the most probable diagnosis? So that is the tetanus. What can you tell me the dose of the tetanus? At the tetanus, what do you see? The patient will be having the lock jaw and there is a spasm of the facial muscles. The spasm of the facial muscles will be there. Difficulty in the swallowing, jaw stiffness, the patient will be having the restlessness. Okay, but main features is what? The lock jaw or the spasm of the facial muscles will be there, and the patient will be having the complicated mouth opening. Then in the history you will get, the patient will get the history of any trauma or iron. Okay, now see it with difficulty because of the, she not able to open the mouth. There are muscles tension on the back of the head and abdomen. Thirdly, there is a tension of all the muscle groups. So what we see? The tension of all the muscles group. What we see? The tonic spasm. The spasm of all the muscles, and they will become highly hypertonous. Generalized convulsions every 10 to 15 minutes. Okay, so there will be some reflexes can be present, and what is the most probable diagnosis? That is the tetanus. Remember, they can ask you dose also for the tetanus, that is the 0.5 ml stat will be given. Stat means immediately, just after the trauma we will give the 0.5 ml stat. After that, gastric juice channel 42-year-old patient, absence of free hydrochloric acid at all the stages. Endoscopy revealed pallor, thinning of the gastric mucosa, smoothen fold. Microscopy, the atrophy of the glands. So our question has been solved. If you see the atrophy of the glands with intestinal metaplasia, so what is this situation is typical for? That the chronic type A gastritis. When we talk about the gastritis, so in case of the gastritis, we see there is a conditions. We will see that like the gastritis, it can be the acute gastritis, the acute gastritis or the chronic gastritis. The acute gastritis, it is caused by the Haemophilus influenzae, Helicobacter pylori, or NSAID, or it can be the autoimmunes. But chronic gastritis, it is divided into three conditions, that is like type A, type B and type C. Then remember that if we see such type of the conditions, so there are the acute conditions. In acute conditions, we see there is a hematemesis will be there. Hematemesis will be there, like blood in vomiting will be there. And can you tell me which is the most common cause of hematemesis? The most common cause of hematemesis, that is peptic ulcer disease. The peptic ulcer disease, this is the most common cause of hematemesis. Can you tell me which ulcer is the most common seen in the peptic ulcer disease? So that is the most common ulcer, that is the duodenal ulcers, and it both are associated with the Helicobacter pylori. Then we will be having chronic gastritis. We will be having the chronic gastritis, and chronic gastritis, remember, this is the three types: A, B or C. A, B or C. Then remember that if we talk about the chronic gastritis type A, the chronic gastritis type A, then type A, remember, there will be the patients is the autoimmune condition. There type A for autoimmunes. Remember, this is the autoimmune conditions will be there. What we will see, there is an antibody will form against the parietal cells. There will be the antibody formed against parietal cell. Against the parietal cells. So these parietal cells, we know that is abundant in the stomach or the abundant in the stomach, in the body or the fundus regions. So there will be the antibody form against these parietal cells. So what is the function of these parietal cells? Can anyone tell me what is the function of the parietal cells? What is the function of parietal cells? Parietal cells, they HCl, okay, hydrochloric acid, HCl production, are also they release the intrinsic factor. Okay, that's why we discuss the macrocytic anemia or megaloblastic anemia. So what you have seen, there is an increase of hydrochloric acid. So they release the hydrochloride secretions, and also they increase the intrinsic factor vitamin for vitamin B12. So what we will see, if there will be the, in these conditions, the autoimmune, then, and after that, if the autoimmune, the other region is the atrophic gastritis. There will be the atrophic gastritis. We also call this as the atrophic gastritis. So what we will see in these conditions, like there is antibody formed against, the antibody will formed against the parietal cell. So there will be decrease in hydrochloric acid. There will be the decrease in the hydrochloric acid. So if decrease in the hydrochloric acid will be there, so there will be hypochlorohydria. There will be hypochlorohydria. In when the hydrochloric acid will be decreased, so there will be the increase of gastrin. There will be the increase of gastrins, and it will cause the hypergastrinemia. It will increase the it will cause the hypergastrinemia. Along with that, what we will see, there is a decrease in the intrinsic factor also. The decrease in the intrinsic factor. So what we will see, their patients will be having the pernicious anemia. There will be the pernicious anemia will be there, and the pernicious anemia, this is due to vitamin B12 deficiency, because this is the intrinsic factor for the vitamin B12. So we call this as the vitamin B12 deficiency. Okay, and due to this increase in the gastrin, hypergastrinemia, the patients can having the cancer. The patients can lead to the cancer, gastrinoma cancers, and the most that the patients can having the cancer, the gastric cancers can be theirs. Okay, who produce the gastrin? Gastrin is produced by the which cell? That is the G cell. The gastrin is produced by which cell? That is the G cell. So G cell, it produces the gastrins by the antrums. The G cells, they present in the antrum regions, and it produces the gastrin, or produce the gastrins. And if there is a decrease in the hydrochloric acid, because the gastrins, G cells stimulate the gastrin, while the gastrins stimulate the parietal cells. The gastrins stimulate the parietal cells. So if the parietal cell, there is antibody formations, antibody will be against the parietal cells, so gastrin will not able to stimulate the parietal cells, and due to which the gastrin level will be increased in our body, and the patients will lead to the hypergastrinemia will be there. Okay, so in this condition we see the atrophic conditions will be there, everything will be decreased. Then second one, the type B. The type B, remember, type B, this is the type. Let's talk about the type B. And the type B gastritis, that is caused by the H. pylori gastritis. Okay, पूरा spelling अच्छे से लिख लेना, gastritis. So it is caused by the H. pylori, Helicobacter pylori. It is caused by the Helicobacter pylori. What they will do? They release the Helicobacter pylori. They release the toxins. They release the toxins like protease, phospholipase, or coagulase A. Okay, what these toxins will do? They will damage the gastric acid mucosa. They will damage the gastric acid mucous barrier. Damage the gastric acid mucous barrier. So if they will damage the gastric acid mucous barrier, it will lead to the gastritis. It will lead to gastritis. It will lead to the gastritis, and if mucous barrier will be damaged, so there will be the stomach ulcer, that is gastric ulcer will be there. The gastric ulcers will be there. Along with that, we see there is a gastric cancer will also be there. Okay, tell me, can you tell me which enzyme is formed by the, which enzyme is secreted by the Helicobacter pylori? Which enzyme is secreted by the Helicobacter pylori? मम्मी जी मम्मी पानी देना पानी 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 देना पानी that is the urease. So that is the urease will be released. That is the urease that is released by the Helicobacter pylori. एक second. That will be released by the guest. So we will see that there is gastritis, gastric ulcers and the gastric cancers will be there. So we will see the type B gastritis H. pylori and they release the toxins. So what these H. pylori will do? The H. pylori they will release the enzymes. The H. pylori they will do they release the enzymes, and which enzymes they will release? That is the urease. That is the urease. What the urease do? Urease क्या करता है? Urease will convert urea to ammonia. Urease convert urea to ammonia, and ammonia is what? That the alkaline substance. The ammonia is what? That is the alkali substance, and this ammonia is what? That is the alkali substance. That is the alkali, like the basic substance. To neutralize this alkali, our gastric part like parietal cell will increase the more HCl's. If due to which this is the alkali, and due to which we see there will be the increase of what? Hydrochloric acids by the parietal cell. The increase of hydrochloric acids to neutralize the ammonia. Okay. ठीक है. So if the type B gastritis, that is H. pylori will be mentioned, and the toxins, they release the toxins due to which damage the gastric acid mucous barrier, that will cause the gastritis, gastric ulcer, gastric cancer. And this H. pylori release the enzyme like urease enzyme they release, and they convert the urea into the ammonia, and ammonia is not alkali substance, and due to this ammonia our body will produce more and more, and our body will produce more hydrochloric acids. So when the more hydrochloric acids will be formed, it will neutralize the ammonia, and that's why it will be lead to the more productions, and the patient will be having the inflammatory gastritis. Okay, like barrier has been lost. So barrier has been lost. See digit respect. This is sports UP class 10th ऊपर प्राची निकम्स. Okay. होना है तो okay, so this is what? That is the gastritis. एक होता है हमारे पास टाइप सी बोले या फिर हम बोले कि स्पेशल गैस्ट्राइटिस. एक क्या बोले? टाइप सी या फिर बोले स्पेशल गैस्ट्राइटिस. बेसिकली द टाइप सी कुछ नहीं होता. टाइप सी जो होता है दैट इज ड्यू टू like NSAID or any other activities. So that is what? Type C gastritis. Other than that we see there is a special gastritis will be there. Other than that we see there is a special, there will see the special gastritis, and the special gastritis they will not ask you. Special gastritis will be there, and we talk about the special gastritis. So remember that if the special gastritis, like the special in the terms of their names, like for example there is a one we call is the Meniere's disease. In Meniere's disease, what we see, if we see there is a gross hypertrophy of the gastric mucus fold, so that is the Meniere's disease. What we will see, the gross hypertrophy, there is a gross hypertrophy of gastric mucus folds, gross hypertrophy of the gastric mucosal folds. So that is what? Meniere's disease, and this is the pre-malignant condition. एक होता है that is erosive gastritis. एक होता है erosive gastritis. If gastritis is specially due to NSAID, If NSAID due to NSAID, so that is what erosive gastritis. That is the erosive gastritis. Other than that, if it can be eosinophilic gastritis, that is the allergic, and it can be the reflux gastritis, like if it is due to some alkalines or reflux to the of alkaline from the jejunum into the stomachs, because in alkaline we have in the jejunum parts we have the more alkali natures will be there. So if there is alkali substance reflux into the stomach, so that will lead to the reflux gastritis. जैसे हम बोल देते हैं, in case of the GERD we have the reflux from the stomach into the esophagus. Same things we have discussed in the reflux gastritis. Reflux gastritis, if we see there is a reflux of alkali from jejunum to stomach, because the small intestine having a more alkali nature and they have the pH is more alkali, because they have the alkaline secretions will be there. Reflux of the alkali from the jejunum to stomach, so that is the reflux gastritis. Okay, so now you can do the questions. What are the questions saying? We have the free hydrochloric acid at all the stages. Endoscopy reveals pallor, thickening of the gastric mucosa, smooth folds. Microscopy we see the atrophy of the glands with the intestinal metaplasia was found. So what disease is that? That is the atrophy, like the glands has been atrophied because of the decrease in hydrochloric secretions. So that's why we will be having the chronic type A gastritis. Meningitis disease, I told you, the gross hypertrophy of the gastric mucosal folds, and it is the pre-malignant conditions. Pre-malignant condition. Then we will be having the non-specific ulcerative colitis. The non-specific ulcerative colitis, I told you that we are having the two disorders, the Crohn's disease, and we will be having the ulcerative colitis. And ulcerative colitis, we discuss everything that it involves the mucosa, submucosa. Okay, it is not transmurals. What other we discussed? That is the collar button ulcers, pseudopolyp, and the lead pipe appearance we will see in case of the ulcerative colitis. Lead pipe appearance. And in case of the Crohn's disease, what we see, the sting signs of calor will be seen, cantor, or the sting sign of the cantor will be seen, and also they are associated with some extraintestinal manifestations. And extraintestinal manifestation, I told you that if there is associated with the joints also, like ankylosing spondylitis, polyarthropathy, or the sacroiliitis. They are also associated with the eyes, like the uveitis, claritis. They are associated with the skins, and the skin, they ask you that from by which skin disorder it is asked. It is associated, this is the pyoderma gangrenosum. It is associated with, and also they are associated with the cholangitis and cholangiocarcinoma. So means, like I told you, for the treatment, remember what we will do? We do the steroidal treatments. We do the steroids. If the steroids are not available, then we can go for the 5-amino salicylate. 5-amino salicylates. And 5-amino salicylates we will given in the which condition? In acute inflammatory condition. 5-amino salicylate in acute conditions. If still it is not, we can use the immunomodulators, that is the levamisole. The levamisole, it is used as an immunomodulator in specific ulcerative colitis. Okay. After that, we have discussed everything about the pyelonephritis. So this is the case of the chronic pyelonephritis. Okay, like in the pyelonephritis, there will be the WBC cast in the urines, and there is Pasternitsky sign will be there. So we have seen there is a minor costovertebral angle tenderness, that is the Pasternitsky sign. Now see, if you want to differentiate the acute and chronic. So what you will see, the patient will be having the enlarged kidney. The patient will be having the a large kidney will be there, and these patients will be having the contracted kidney. These patients will be having the contracted kidney will be there. Other than that, if we see that these patients like acute pyelonephritis patients, we will see there is a small yellowish foci will be there, means with the cortical abscess will be there. The cortical abscess will be there, and in this patient we will see that there is a second point here, that is the saccade, cortex and medulla will be there. Means they are completely not demarcated from each other, they are completely joined with each other. We cannot differentiate which is we cannot differentiate which is cortex and which is medulla. Along with that, we see there is a no change in the glomeruli. There is a no change here, no change in glomeruli, no change in glomeruli. But in chronic, we see there is a glomerular sclerosis can be seen. Glomerular sclerosis can be seen. Okay. And all other things that we discussed. After that, the next questions we see there is a dyspnea and exertions, attack of the retrosternal pain, dizziness. He has no history of the rheumatisms. So there is no history of the rheumatisms. So we have discussed. So what we have discussed about here. So this is what. Halanki, this is not completely associated with this condition, but we have the seen that mitral stenosis and the tricuspid stenosis or the mitral regurgitations, they are associated with the rheumatic heart disease. So these three will be ruled out. So these three will be ruled out. Then remember that if we have in the questions, if you will no history of rheumatisms, can be ruled out the no mitral stenosis, no tricuspid stenosis and no mitral regurgitations will be there. So what we've seen, pale skin, acrocyanosis, there are the rails in the lower part of the region, systolic thrill in the second intercostal space on the right, core systolic murmur conducted on the vessels. So see where this we have seen the second intercostal space. The second intercostal space, now again come back, we have seen the second intercostal space. We have seen there is a second intercostal space. So the aortic area, second intercostal space. Or at pulmonary area, the second intercostal space. Here we will the right second, but the pulmonary regurgitations. Okay, so aortic, or we have seen the aortic, that is the second intercostal or pulmonary. Means these both are the possibles. Means mitral or tricuspid will not be the answer. So you can rule out this one, rule out this ones, because they include the and ventricular septal defect. Of course, that will be the not the answer. Then we have seen there is a systolic thrill in the second intercostal space on the right. Now right side, core systolic murmur conducted on the vessels of the neck. AP 130. So I told you that when we have to hear the aortic sounds, so aortic sounds will be here on the right side. The aortic sounds will be here on the right side, because this aortic will be go like this and the pulmonary aorta will be go like this. So we will hear the heart sounds on the right side in case of the aorta. Then AP is there, liver extend 5 cm under the edge of the costal arc, seen edema or present, specify the assumed valvular defect. So what you will classify from here? Okay, tell me which murmur will be here, that is the ejection systolic murmur, that is the ejection systolic murmur is there. Okay. So here we will be having that is the core systolic murmur. The core systolic murmur means that is the some murmur study will be there, but that is the systolic murmur. So systolic murmur is seen in the systolic. Then we have the second intercostal space. Then we will see there is a aortic stenosis. Okay, other is any other options is there? Diastolic murmur? No, that's why it will be ruled out. That's why it will be ruled out. Okay, so that's why it not be the answer. So like this you can do this type of the questions. Okay, is that clear? इस क्वेश्चन में किसी को कोई डाउट? इस क्वेश्चन में किसी को कोई डाउट है तो बता दो, नहीं तो मैं आगे चलूंगा, मैं आगे बढ़ूंगा। एवरीथिंग इज क्लियर? गिव मी हैंड्स अप, थम्स अप, सॉरी हैंड्स अप नहीं, थम्स अप। ठीक है, ओके, गुड। Okay, like this type of the questions will be asked from the valvular defects. And also remember, like if they will ask you directly, if you want to remember the systolic murmur. Murmur ke I think I wrote here. If the case of the eject is the systolic murmur, so there we will see the SV stenosis. If it is the case of the semi-bullous regurgitation, we see there will be the early diastolic murmur. If it is the case of the AV regurgitation, we see the PS. So remember this one separately. That will help you. Okay, everything we have written. No need to write. Okay, after that we see a 24-year-old female teacher complained dizziness, heart pain, radiating to the left nipple. Female teacher is there and 24-year. Pain is not associated with the physical activity and cannot be relieved by the nitroglycerin. The pain cannot be relieved by the nitroglycerin. It abates after taking the valcorodin and lasts for an hour or more. The patient has nearly 2 year history of the disease. Heart borders are normal, heart sound clear. The ECG showed respiratory arrhythmia. Radiograph of the cervicothoracic spine shows no pathology. Lungs, abdomen are unremarkable. What changes the blood formula can be expected? So what we will see? Did you see any organic changes? Here you see the radiograph shows no pathology. Heart borders are normal. Heart sounds are clear. ECG shows the respiratory arrhythmia. The respiratory arrhythmia we can see that is like normal things. Respiratory arrhythmia means like the respiratory like little heart rate or little bit up and down can be seen. Okay, that is the again like lead to the normal condition only. The lung abdomens are unremarkable. Everything, if the I told you if anything like involvement of any organs are there and there is some pathology is there and patients will be the female, but this is the most probably you will get the female. The pain is not associated with any physical. This is the same question that we have done. Okay, so that's why we will be having again the same question, that is the somatoform autonomic dysfunctions. Okay, no organic disease is there, so that is the no changes will be seen, can be expected. Again the same questions. Sigmoid is painful, there is a weight loss, defecations, liquid blood stick schools. Okay, ulcerative colitis. See, this is the celiac proof, celiac disease. ECG has revealed both ventricles hypertrophy. देखो, this question is simple questions. What doctor tactics should be? A 18-year female student is there, complained of the dyspnea during the intensive exercise. The condition become worse half a year ago. On examination, we see the pulse rate is 88, accelerated, AP is itna, pale skin, heart borders are dilated to the left and up. There is systolic diastolic murmur in the. There is a systolic diastolic murmur, means heart's problem is there in the diastolic. So it can be the aortic stenosis, it can be the regurgitations. S2 at pulmonary heart is accentuated. Accentuated means like some dimness sound is there. Okay, that is the accentuated. एक सेकेंड, इसका मतलब दबाव, हिंदी में बोलते हैं दबाव का चिन्ह. एसिन्यूएट मतलब दबाव का चिन्ह. जैसे हम किसी चीज को लाइक फॉर एग्जांपल अंडरलाइन. ओके, द वर्ड सिमिलर टू द लाइक द अंडरलाइन. ठीक है, लाइक वी हैव पुट समथिंग we have the precise some things, and that we will get the some sign on there. So that will be the dabav ka sign. ECG reveals both ventricular hypertrophy. So how you will go to the patient doctor tactics. So what to do? The cardiosurgeon consultation, because the patient is having the cardiac abnormality or cardiac pathology. After that, a 49-year-old patient complained of the dyspnea of the combined nature, cough, seen edemata, abdomen enlargement due to ascites. He has 20-year history of the chronic bronchitis. For the last year, he has been disabled because of cardiac changes. Objectively, we see the mixed cyanosis, edemata, rhythmic. There is a accentuation. Accentuation, you can say the prominent also. Matlab meaning of here, the prominent also, the prominent one of the second sound above the pulmonary artery. Auscultation reveals the Bach's resonance above the lungs. There are also the dry rails over the entire surface. What is the mechanism of heart changes developed in these patients? Now see, this is the condition that we seen in case of the one disorder, that is the hypoxic pulmonary vasoconstrictions. That is seen in hypoxic pulmonary vasoconstriction. The hypoxic pulmonary vasoconstrictions will be there. So what is the mechanism heart changes that develop in this patient? The hypoxic pulmonary, that is known as this reflex, because see this one, remember this one, Euler-Liljestrand reflex, Euler-Liljestrand reflex, and this reflex is also known as the alveolar vascular reflex. This reflex is also known as the alveolar vascular reflex, alveolar vascular reflex, alveolar vascular reflex, and this is given by, and this is known clinically as the hypoxic pulmonary vasoconstrictions. So it tells us about the difference between what is the ventilations, difference between or relation between the ventilations, duration between the ventilation and blood flow, relation between the ventilation and blood flow. देखो ब्लड वेंटिलेशन की बात आती है तो हम क्या बोलते हैं नॉर्मली वेंटिलेशन से, ठीक है, डायरेक्टली, बट वी हैव टेल द परफ्यूजन, ब्लड फ्लो मतलब परफ्यूजन, ठीक है. सो दैट इज लाइक V by Q, इसको हम लिखते हैं V by Q, दैट इज द इक्वल टू V by Q. So V means ventilations and Q means that is the perfusions. V by Q quotient will be there. So this is measure the ventilations quotient ratio. So what we will see here in these conditions, the here this is actually we can say this is like in simple terms, if we say that is the, as the name is saying, hypoxic pulmonary vasoconstriction, there is a decrease in the oxygen supply related to the lungs and there will be the vasoconstriction. So now understand this question. So the patient will be having the dyspnea of the combined nature, cough, seen edemata, abdominal enlargement due to ascites. Okay, he has 20-year history of the chronic bronchitis. So they have the some pulmonary pathology there. For the last 3 years, he has been disabled, group 2. Okay, because of the cardiac changes, mixed cyanosis, edema. Respiration rate is also little more. Okay, there is a attenuation of the second sound above the pulmonary artery. Auscultation reveals the band box resonance above the lungs, and there is also dry rails over the entire surface. So what we have seen that if any pulmonary pathology, and we will measure here the ventilation perfusion ratio, ventilations perfusion ratio, and this ratio will tell us how much the patients will be having the hypoxic conditions. This will tell us how much the patient will be having the hypoxic conditions will be there. Because if this patient will be having like in case of the reduced ventilation means that oxygen will be reduced. Okay, if oxygen will be reduced, and that will lead to the reduced perfusion, because ventilation means like if the patient will be having the oxygen is coming, and perfusion means that is direct oxygen is going from alveoli to the lung tissues, that is like diffusing from the alveoli. So that is the perfusions. So if less oxygen, less ventilations will become, so less oxygen will be lead to there, and it will reduce the perfusion, and due to which we will see this mechanism is what that is known as hypoxic pulmonary vasoconstriction. Because of decrease in the oxygen supply, there is a decrease in the perfusions. So that's why we call it the hypoxic. And like is it related to the lungs alveoli condition, that pulmonary and the vasoconstrictions will be there. Okay, and the name of this reflex is known as the Euler-Liljestrand reflex. After that, question number 120, if we see that patient having the sudden complaint of the strong headache in the templates, in the temporal area, and in the area of the orbit, dull pain in the body, dry painful cough, his temperature is increasing, temperature is more, and the patient mucous membrane of oropharynx, if the mucopharynx of oropharynx, the reals are not auscultated, so what is this condition? This is what, that is the influenza, and this is the adult person, so the adult person will be having the influenza conditions, and the patients will be having the fever. Along with that, the flaming oropharynx will be there. The next is what? Pheochromocytoma. In pheochromocytoma, this is the neuroendocrine tumor of the which? It is the neuroendocrine tumor of medulla of medulla. Medulla is part of adrenal glands. Okay. If origin, if we talk about the where it originated, so its origin is the chromaffin cells. Its origin is the chromaffin cells. Okay, and that will lead to the pheochromocytoma. So there will be the increase in the everything. Like there is increase in the blood pressures. You will see all these things will be seen in the pheochromocytoma. Then pheochromocytoma, remember there is a more adrenaline. The patient will be having the headache, sweatings, fast heartbeats, shakings, irritability, angina, anxiety, weakness, and the other things that you will see. The important things I am writing here, that the palpitations. These patients will be having the palpitations, tachycardia, and remember the sweating also. And these patients will be having the hypertension, polyuria and polydipsia. So all these things are seen in case of the pheochromocytoma. This is the tumor of the adrenal medulla. So you see the palpitations, you see the tremors will be there, and there is increase in the arterial pressures, and the blood, you see the WBC, blood glucose will be high. That is what disease is the most likely cause, that is the pheochromocytoma will be there. And adrenal medulla, you know that what is, it's release the sympathetic and parasympathetic system. So that's why, because this is the neuroendocrine tumors, and the sympathetic activity will be increased in this condition. A 76-year-old male consulted a therapist about the slow discharge of urine with small jars. The patient reported cardiac problem. Examination revealed there is atrial fibrillation with a heart rate of 72 per minute and without pulse deficient. What is the heart rate of the patients? 72. No pulse deficit is there. No sign of heart failure. ECG confirmed the presence of the atrial fibrillations. So who will tell me what is the heart rate you seen in case of the atrial fibrillations? Who will tell what is the heart rate? What heart rate we have seen in case of the atrial fibrillation? What heart rate we seen? That is 250, 100 plus. Okay, so we have discussed everything. Which one is correct? 250, 100 plus. Tell me the exact what I told you. Tell me the exact what I told you. ओके देखो, एक बार दोबारा देख लो ये. Ventricular flutters वाइड क्यूरस एंड वेंट्रिकुलर फिब्रिलेशंस, ठीक है। उसके बाद in case of the ventricular tachycardia we discussed the heart rate will be more than 100. Then if it is the case of the PSVT, in the PSVT you need to remember the accessory pathway. Atrial flutters, you have to remember that the heart rate will be more than 250 per minute. If it is the case of the atrial fibrillation, then heart rate will be more than 350 per minute. The heart rate more than 350. देखो flutter क्या है? Flutter 1 2 1 2 3 4 5 6 7, okay. Fibrillation 1 2 3 4 5 6 7 8 9 10 11 12, okay. So it is the big word, so that's why more heart rate will be there. In flutter we will be having the less words, so that's why we will be having the less heart rate, okay. And tachycardia means that is 100 to 250, 100 to 250, so more than 250 flutter, more than 350 you will be having the fibrillations, okay. After that, don't confuse. Here you see that everything is normal, in the like around normal things, so that's why we don't have to give any, does not require treatment, because they are just telling the history. The patient is coming just to check up, the patient is come just to for follow up, if any complication has been done or not. So this patient is what, that patient is very normal patient, so do no need to worry about in this patient about anything. Okay, is that clear? After that we will be having, that we have done irritable colon syndrome or bowel syndrome. That is the same questions that we have discussed. Irritable colon syndromes or the bowel syndromes. Then if you see the any ethyl gasoline, so it means that most likely diagnosis will be the ethyl admitted to the hospital with the complaint of the general weakness, dizziness, memory impairment, sleepiness at the daytime, insomnia at the night, sensation of hair in the mouth, colicky pain in the right subcostal area. So they all are the treatment of the lead intoxication. Ethyl gasolines means there is a lead, and that means the chronic tetraethyl lead intoxications will be that, like the complication, the toxicity of the ethyl gasoline has been there. So these patients will be having this type of the symptoms. After that, the questions number 125. A 35-year-old patient has been in the intensive care unit for acute renal failure due to CRUS for 4 days. Objectively, the patient is inadequate, breathing time 32 per minute. Over the last 3 hours, individual moist trails can be auscultated in the lungs. ECG shows high T waves. ECG shows the high T waves, right ventricular extrasystoles, CVP 159, residual nitrogen 72, potassium 7.1, chloride 78, sodium is there, high hemoglobin, blood creatinine, that is 0.9 millimole per liters. The most appropriate method of treatment would be, the first things that if you see that the blood creatinine levels, you see the blood creatinine levels, if the increase in the, this is the increase in the creatinine levels, if there is an increase in the creatinine level, increase in the creatinine levels, if you say the normal is what, that is 106 micromole per liter, 106 micromole per liter, or you can say 0.106 millimole per liters, 0.106 millimole per liters, okay. If you will convert this it into the micro, so it will become the 106, so it is 0.106 millimole per liter. So of course this is what, that is the blood creatinine level is the more. So this is the sign that if increase in creatinine, this is the sign of the kidney damage, the patient will be having the kidney damage. Other than that, if you see there is an increase in the hyperkalemia, if you see there is an increase in the hyperkalemia, if hyperkalemia, it means potassium is more than equal to 5 millimole per liters, or 5 milli equivalent per liters, so that means the patient will be having the kidney damage. Other than that, we see the blood urea nitrogens that will be more than 15. Blood urea nitrogens that more than 15, so that is also the sign of the kidney damage. So in all these patients, what we have to do? We have to do the hemodialysis. We have to do the hemodialysis. The hemodialysis will be there. Okay, the hemodialysis will be done in these patients. So remember these things. If you have the acute renal failure is there, and the residual nitrogens like blood urea nitrogens, if it is more than 15, so that is the here we have the 62. Potassium, that is the 7 point, is also the hyperkalemia is given, and the sodium, what is the normal level of the sodium? 135 to 145. The sodium level will be decreased. The sodium level is a decrease here, and the hematocrit and hemoglobin is 100. Blood creatinines will also the most appropriate method of the treatment. So this is the patient having the kidney damage or the renal failure. So in that patient we will go for the hemodialysis. Why the hemodialysis will be done? To remove the excess fluids in the body. So with the help of the hemodialysis we will do that. So we having the patient brought to complain of the pain that started suddenly in the left chest part and epigastric area. Shortness of the breath, nausea, one-time vomiting. The acute pain started after the weight lifting. The acute pain started after the weight lifting. On physical examination, the shallow breathing, respiratory rate is there, that is increased. The left chest part is behind during the respirations. So that is means some pulmonary, there is some pulmonary pathology has been mentioned. So that's why we will do in this patient. That will be the on percussions we see the tympanic sound we seen in case of the pneumothorax. Respiration not auscultated, pulse rate weak, filling, blood insignificant displacement of the heart to the right, sounds are dull, or we can say the mediastinal displacement of the heart to the right. So that is the what you will do in case of the pneumothorax. So this is the chances the patient can be having the pneumothorax. So what we will do, the X-ray or the röntgenography. If the patient having the aplastic anemia, so aplastic anemia, there will be the bone marrow suppressions. If the aplastic anemia, the patient will be having the bone marrow suppressions. So that's why we will be having set punctures has been administered with the diagnostic purpose. What changes the marrow puncture has suggested? What will do? Replacement of marrow elements with the adipose tissue. Because aplastic anemia, there is a bone marrow compressions, bone marrow suppressions will be there. Bone marrow will not able to produce the white blood cells, the red blood cells. So what are the changes in the marrow punctum? Because this marrow elements has been replaced with the adipose tissue, that's why they are not able to form the platelets, that will not able to form the RBC, that's why not able to form the WBC or leukocyte erythrocyte platelets will not be formed. We see that this patient will be having the bleeding gums, dizziness, the mucous membrane and skin are pale, numerous hemorrhage, various topics. Blood test results, there is color index is 0.9, anisocytosis, poikilocytosis. In which condition we see the anisocytosis or the poikilocytosis? What is the meaning of anisocytosis or the poikilocytosis? What is the meaning of anisocytosis? Yes, more than 350, it was correct. What is anisocytosis? What is anisocytosis? What is poikilocytosis? Size of RBC, the RBC of different size, दोनों अलग अलग होते हैं ना. तो एनिसो देखो, रिमेंबर द PP जा, PP is the name of someone. What we calling the PP जा कबूतर जा. तो यहाँ पे हमें क्या बोलना है? PP जा और PP जा. So मतलब P4 we having the shape. P4 we having the shape of RBC, or we will be having the abnormal shape of RBC. We will be having the abnormal shape of the RBC. Anisocytosis. So anisocytosis we will be having Ja. So A4 we will be having A, aniso, and Z4 we will be having the, that is size. The size of the abnormal size of the RBC. The abnormal size of RBC will be there. Okay, so what laboratory test is to be determined next for making the diagnosis? So this is the case of the anemia, but we have to firstly understand the patient have the bleeding gums also. So these patients can having the thrombocytopenia also. So that's why we have to exclude, because if the bleeding gums is there, and also we see the in case of the ITP also, idiopathic thrombocytopenic purpura, we have seen that if the platelets will not be present, there will be no clotting formations will be there, and that's why we have to firstly check whether it's the platelets is there or not. So with the decrease in the platelets or not, there is a chances of thrombocytopenia is possible. That's why we will do the platelet test. If there is a goiter condition, so what preparations most likely to prevent the disease recurrence? So what you will do? Thyroid hormone. Central cancer of the lungs, we have the seen the triangular shadow in the area of the lower lobe that is connected to the mediastinum. So means that is present in the central area, that we have the central cancer of the lungs. So the same questions that we discussed yesterday. There is a thromboembolism formations due to some thrombophlebitis agents. So there is a thromboembolism of the pulmonary artery. Now see what tactics is necessary to improve the condition of these patients. We have consultation of expert in the narcology, infectious disease doctors. Now see the questions. Ask for more. A 19-year complaint of the pain in the abdomen and joint. Ask for more analgesics and somniform injection. He is asking for the analgesics and the somnificient injection. The patient was examined. Gynecology, urological pathology are absent. There are the sign of previous puncture along the superficial vein. What you have seen, the sign of the previous punctures along the superficial vein of the extremities. The patient does not explain this. So this patient is what? The tender reflex of upper and lower extremity same quick. Photoreaction of the pupils of the eye is weak. The tongue is grey coated. During communication, the patient is in the affected, not even tempered. There is a diarrhea without pathological inclusion. So what you will do? You will send these patients to the narcology department. What you will do in the narcology department? You are the samajhdar person, so you know what you need to do. So what this patient was doing, what this person was doing, he was doing. Okay, so they have the smokes, anything has been done. He was putting the injections of the analgesics or the painkillers, was the addiction of having the smoke. Okay, so that is the consultation of the expert in the narcology. So what you will do? We send the patient in the narcology department. Rheumatoid arthritis, methotrexate. So what you have seen, the diastolic murmur with pre-systolic intensifications, opening snap. Where you see the opening snap, opening snap, opening snap, opening snap, opening snap. Oh, the opening snap किस में देखेंगे? The opening snap due to high pressure opening of the AV walls, increase in the left mitral stenosis, right atriums there is a conditions. So what you have seen, the mitral stenosis, we see the mid diastolic murmur. Where we what we see? Mid diastolic murmur. So murmur, mur, 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 mur. Mur, 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 mur. So murmur opening snap, we have seen the diastolic murmur. So mid diastolic murmur with pre-systolic intensification, that is given that there is a mid diastolic murmur. So as to extend at the pulmonary artery, what ring of heart disorder is observed? So that is the mitral stenosis. देखो उस टेबल से कितना इजी हो गया. अगर उस टेबल को तुमने अच्छे से रट लिया, समझ नहीं लिया पर स्टिल रट भी लिया ना, तो भी काम हो जाएगा. तो क्या तो उसको रट लो या समझ लो। रट समझ के करोगे, समझ समझ के रटोगे ना तो अच्छा रहेगा। समझ समझ के जो रटे उसकी समझ कुछ आए, समझ समझ के जो रटे उसकी समझ कुछ आए, बाकी तो किसी को ना कुछ आए ना कुछ जाए। वाह 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 वाह। एनी सो पोई किलो, ठीक है। सो डू दैट। Here what you will do, sensation having distension in the epigastriums immediately after the meals. So which ulcer is there? Pain in the epigastriums immediately after the meal. तो वो अगर तुमने अच्छे से पढ़ा है ना, अगर तुमने अच्छे से पढ़ा है then definitely you can answer just with the one line. Immediately after the meals क्या होगा? Which ulcer will be there? तुरंत आंसर आना चाहिए, यूं आंसर आना चाहिए चुटकियों में. So that is the gastric ulcer. So the pain occur after 2 to 3 hours. Then which ulcer? Pain occur after 2 to 3 hours. Which ulcer? अच्छा, किसी ने इंस्टाग्राम की जो वाली मैंने अभी रील्स पोस्ट करी है, अगर वो देखी हो तो वो रील में फास्ट लग रही है, स्लो लग रही है? फास्ट. Today was about the peptic ulcers, right? So peptic ulcers I post that you can see there. ठीक है, अगर किसी को कुछ डाउट है देन सी दैट इंस्टाग्राम वीडियो. कहाँ पे हो तुम? डॉक्टर्स, यू आर द डॉक्टर्स याओ. So that is what we will do the investigations. We do the esophageal gastroduodenoscopy. Esophageal gastroduodenoscopy will be there. pH-metry or all these things will be done later on, but here we will do the most informative, so that is the esophageals. If it is not like we have to go further onwards, then we go for the pH-metry. A patients complain of the deglutination problems, especially with the solid food. Okay, this is the case of the, maybe they are wanted to talk about the esophageal cancer. So what you will do, the biopsy to rule out the cancer. क्लास क्लास ले, बाद में करता हूँ. फैंटास्टिक. पढ़ रहा हूँ, मोस्ट वाले भी कर ले. एक सेकेंड. Okay, so the next question is what? A 60-year-old patient has been admitted to hospital with the complaint of the dyspnea, tightness in the right subcostal area, abdominal enlargement. This presentation have been progressing for a year. Heart auscultation reveals peristaltic gallop rhythms. प्रीसिस्टोलिक गैलोप रिदम्स कहाँ पे हमने पढ़ा? बता दो कहाँ पे होता है, कहाँ पे होता है, ये कहाँ होता है, बता दो आज. प्रीसिस्टोलिक गैलोप रिदम्स, objective swelling of the neck vein, ascites, palpable levers. What disease require the differential diagnostic? देखो, this we have discussed that in case of the cardiac tamponades, but they are asking about the differential diagnosis. So I told you the differential diagnostics, what you will do, that is the constructive pericarditis, where we see the pre-systolic gallop rhythm. Pre-systolic gallop rhythm will be there. Bolo Jai Mata Ki. आगे नेक्स्ट क्वेश्चंस विल बी देयर। तो आ जाओ नेक्स्ट क्वेश्चन करते हैं आ जाओ करें। ओके, इस 40-year-old पेशेंट द फॉरेस्टर्स कंप्लेन ऑफ द सीवियर हेडेक, बॉडी टेम्परेचर राइज हो गया 39.5 डिग्री सेल्सियस, ट्रेम्बलिंग लिम्स इज देयर, फ्रॉम द पेशेंट हिस्ट्री दे हैड। इसमें मोस्ट ऑफ द क्वेश्चन तो यही है कि तुम कहाँ जाओगे, विच डॉक्टर यू विल चूज। So from the patient history we know that he had seriously cut his hand during the dissection of the killed fox। देखा क्वेश्चन देखना, फॉरेस्टर है, complaints of the severe headache, body temperature rise up to trembling limbs, from the patient history we know that he had seriously cut his hand। चलो देखो, he had seriously cut his hand during the dissection of killed fox। Why he was dissecting the killed fox? The objectively depressed mood, the patient asked not to turn on the light or open the door, any noise caused apparent motor excitation, when he saw a carafe water, he developed convulsive throat spasm, what tactic should an emergency doctor choose? Okay, if you are the person instead of this forester, so what you will do, what you would do? What you will do, which hospitals you will go, botulisms, meningeals, why botulism, meningeals? सोचो भाई सोचो, आंसर क्या होगा, आंसर क्या होगा। देखो किल्ड फोक्स है, या फिर मैं कुत्ता बोल देता और फोक्स की जगह मैं कुत्ता बोल देता तो आंसर क्या होता? इफ द इंस्टेड ऑफ द फोक्स द here it was he was dissecting on dissection of the killed dog, then you understand which disease I am talking about। अरे अभी तो बता दो यार। रेबीज, हाइड्रोफोबिया, रेबीज, रेबीज। देखो तो फोक्स भी तो क्या होती है, फोक्स, डॉग, दे ऑल आर द, when he saw a carafe of the water, he developed the convulsive throat spasm। ठीक है, depressed mood, the patient asked not to turn on the light or open the door, so what was that? Hydrophobia, phonophobia, हाइड्रोफोबिया, फोनोफोबिया। खुली आंखों से देखो, मेरी आंखों से देखो, तुम्हें सब कुछ दिखेगा, जो भी तुम्हारी आंखों में नहीं दिख रहा वो मेरी आंखों से देखो, है ना, तो वो तुम्हें सब कुछ दिखेगा। So that is hydrophobia, phonophobia। तो deliver the patient to the infectious disease hospital because there is a patient having the rabies can be there। Then a 28-year woman, 12-year history of the chronic glomerulonephritis with a left hand course over the past 6 months, a deal of general weakness, loss of appetite, low work performance, nausea, patient got headache, pain in the neck, anemia, blood urea is a blood creatinine is there, hyperkalemia is there, what complication has been developed? Now you have seen the patient have the history of the chronic glomerulonephritis that has been complicated to cause the chronic renal insufficiency। Okay। Then a patient having the moderate headache, 2 days later develop progressing speech disorders and weakens in the right extremity. The patient has a history of myocardial infarction, arrhythmia, study of the nerve status revealed and in case of the myocardial infarction, what you will see? The ischemic heart problems or the ischemic heart disease। Element of the motor aphasia, the central paresis of the 8th, 1st, 12th cranial nerves on the right, central hemiparesis on the same side of hyperesthesia। So what is the most likely diagnosis? देखो जब हम मायोकार्डियल इन्फार्क्शन की बात करते हैं तो वहां पे एक इन्फार्क्ट दिखता है जिसको हम बोलते हैं मायोकार्डियल इन्फार्क्ट। There is a myocardial infarct। This was the question or the image has been given in your future exam FMG। the myocardial infarct will be there. The myocardial infarct will be there, and the myocardial infarct, what we see, the clot will block the blood. So there will be a patient having the, this is the due to ischemia, due to ischemia will be there. Okay, so what do you call this condition? That is the patient will be having the ischemic stroke will be there. Okay, by the stroke, because we have seen that patient having the paresis, hyperesthesia type of the conditions that we seen only in the which conditions? Stroke. Because this blood infarction, this infarct, there the clot formation will be here. So this clot, what it will do? It will stop the blood flow. It will stop blood flow to brain. Stop the blood flow to brain. Okay, that is the ischemic stroke. I think same questions. Okay, I think they are the same questions like around. Okay, so just give me few days, and so I can go for the some revision for you can I can go for the revisions, because I need to write everything for the revision parts, and then I need to make the video also. So that's why I need some time to make that, and I think that the some questions are the new questions. If you have those type of the doubt, try to solve the whole therapy. Can you do, or should I complete it? Can you do the whole therapy? Everyone, I want an answer from everyone. Bablu Singhs, Lodi, Anurag Saini. बिकॉज इट्स नॉट, क्यों टाइम वेस्ट करना ना इन चीज़ों में, क्योंकि वही चीज़ मैं बार बार रिपीट कर रहा हूँ, मेरे को मज़ा नहीं आ रहा, मेरे को भी ऐसा बोर बोर सा लग रहा है. हमजा हसन, ताकि हम कुछ नया नया कर सकते हैं. प्रज्ञाना, हमजा हसन, अनुराग, बबलू, व्हाट अबाउट अदर्स? सेम सेम, आई एग्री. सूरी संधू, ओके. सिद्धार्थ सिंह, अनुज स्वामी. देखो कोई जबरदस्ती नहीं है, मैं तुम्हारे साथ कोई मतलब कोई जबरदस्ती नहीं कह रहा कि तुम कर सकते हो, ठीक है. अगर नहीं कर सकते हो डेफिनेटली मैं करा दूंगा.